Morning, my name is Fiona Mary Aber from IRC's Uganda Country Program. I am the Environmental Health and IPC Manager, overseeing assessments, improvements, and maintenance of IPC in 34 static health facilities. Today, I'll be presenting why improvement in IPC in health facilities alone is not enough in reducing COVID-19 transmission. Health is IRC's largest sector, and prior to the COVID-19 pandemic, we had no standardized way of assessing the IPC status in over 2,500 health facilities the IRC supports or directly manages across the world. And based on the World Health Organization and UNICEF reports, we all know that infection prevention and control in health centers or health facilities is chronically poor globally. In mid-2020, the IRC adopted the UNICEF and WHO Wash Fit tool, producing a minimum package IPC standard for COVID-19. This tool aimed at to firstly identify gaps as well as enable rapid IPC improvements in health facilities. The IRC's adopted tool looks in more detail at IPC requirements rather than just focusing on basic wash infrastructure. And one of the main adaptations the IRC made was the inclusion of the screening and triage category, as well as including availability of essential PPE materials under the hygiene, environmental cleaning and disinfection and PPE category. And then another minor change the IRC made in the WashFit tool was in assessing and producing aggregated scores for individual categories, as well as an average overall IPC score per health facility. This was to enable comparisons and tracking of individual health facility performance over time. This slide represents the initial IPC baseline results from March 2020. IRC supported health facilities in Uganda using the IRC adapted WashFit tool. The health facilities overall or average IPC score is calculated across the 5 categories, namely the screening and triage and isolation, environmental hygiene, cleaning and disinfection, and provision of essential COVID PPE, water supply, sanitation and clinical waste management, as well as IPC management at the facility. So under IRC's adapted tool, a health facility will meet minimum IPC standards when the overall or the average IPC score is 80% and above. The IRC Uganda Country Program does not have community wash programs. However, the main COVID prevention focus was on improving IPC standards within the health facilities IRC supports. So as seen from the graph the overalls, this is the overall scores over time. So the Uganda IPC EH team was and continues to be very successful in not only improving but sustaining very high IPC scores in health centers over time. So this was helpful by eliciting over $500,000 from public and private donors, specifically for IPC improvements in 2020 and 2021. So far, IRC has secured a reduced amount of funding from the same donors. Early on in the COVID-19 pandemic, the World Health Organization stated that healthcare workers were 4 times at greater risk of contracting the virus than the general public. IRC Uganda's IPC and health team worked rigorously to improve IPC standards within the health facilities. They support in order to reduce the risk of nosocomial infections among healthcare workers. This graph basically shows the 3 official waves of COVID-19 in Uganda, with the number of IRC healthcare workers that tested positive. When this is compared to the overall IPC scores of all of the IRC's health centers, the high numbers of healthcare workers, you can see that the health facility IPC scores was still high, and the most likely place the healthcare workers picked up COVID-19 was out of the health facilities. This is backed up by the very high numbers of IRC healthcare workers testing positive during the third wave. The Omicron variant surge or the third wave of COVID-19 in Uganda coincided with the holiday season in December 2021 to early January 2022, and so many IRC healthcare workers traveled to their home states for well-deserved leave. So IRC has an IPC policy of testing staff before they return to their workplace. This testing protocol found that 172, that is about 21% of healthcare workers reported for work with COVID-19 after their home leave, as seen in the graph. This massive spike in staff infection rates during the third wave highlights the risk of community transmission, which also negatively impacted on the capacity of IRC to maintain quality of care and provision of essential health services. Yes, so some of the limitations IRC has had is that initially the IRC COVID-19 activities were almost entirely focused on improving and maintaining IPC at health facility level, with very few activities focusing on community or household level IPC awareness and behavior change at the start of the pandemic. And however, in light of the number of healthcare workers reporting to work with COVID-19 after their leave, highlighted a significant gap in IRC's efforts to reduce transmission. So health facility focused awareness raising on COVID and other health topics by healthcare workers were proven not to be sufficient. So more comprehensive and holistic approach, for instance, hygiene promotion, formative research, including intensive barrier analysis and risk assessment for community interventions are required. Within the IRC, we have made IPC everyone's responsibility and not just the responsibilities of the IPC, environmental health, or the general health team. And this is paramount in the adoption and success in improving IPC generally and not just IPC in health centers. So other sectors also, such as protection and community health, have shared COVID prevention messages at health centers, in schools, and at community level. However, for health and hygiene messages to be effective, there must be full barrier analysis carried out to help focus risk communication and community engagement. And also, behavior change is essential and a key component in controlling any disease outbreak, especially COVID-19, and most certainly this will not be done effectively just by holding awareness sessions. And so without addressing real or perceived barriers to taking up awareness messages around COVID and other transmissible diseases, then prevention can be assumed that healthcare workers as well as the general population will continue to be affected by such diseases. So IRC has got 3 key takeaways out of this. The first one being that regular monitoring and dedicated IPC watch staff can have a significant impact on improving and sustaining health facility IPC scores. And then secondly, a solely facility-based programmatic focus can compromise efforts to reduce community COVID-19 transmission. And finally, an integrated response combining health, IPC, WASH, and community level behavior change is greatly or highly recommended.